Thank you. Thank you for the introduction, and thank you to those of you joining today. So, the title for my presentation today is Achieving Equitable Access to Diabetes Technologies, a Challenge. And I'll be also speaking specifically about a research project my group is leading, which we call Equated, standing for Equitable and Appropriate Use of Technologies for Adults with Type 1 Diabetes. So just a brief outline of what I'll speak about today. First, I'll do an introduction to diabetes technologies just to make sure we all have some foundational knowledge in that area. Then I'll discuss inequities in diabetes technology access and use. And this is using better registry data that we were able to look at this. I'll talk a little bit about barriers and enablers to diabetes technology access and use, and then some strategies for improving equitable access to diabetes technologies. So, just a brief introduction to ensure we're all on the same page. Diabetes is a condition in which the body either cannot produce insulin or cannot properly use the insulin it does produce. And the role of insulin is to regulate the amount of sugar or glucose in the blood, which must be regulated carefully to ensure proper functioning. So specifically, type 1 diabetes is an autoimmune condition in which the immune system destroys over time the insulin producing cells of the pancreas, leading to a loss of insulin production. So treatment is therefore based on insulin, which must be administered daily, and this can be done through injections or aided through the use of diabetes technologies in order to regulate blood glucose. Um, The importance of regulating blood sugar levels is related to long-term complications, which increase if blood sugar levels are not regulated. So this can lead to complications with vision, called diabetic retinopathy, complications with the kidney, called diabetic nephropathy, with the nerves, called diabetic neuropathy, and also can lead to issues with heart disease. So, as I mentioned, people with type 1 diabetes need to inject insulin or use diabetes technologies to ensure that the correct amount of insulin is delivered. And there have been a number of developments in technology that can make it easier for people to manage diabetes using some of these devices, such as insulin pumps, continuous glucose monitors, or CGM, or closed loop systems, which we'll talk about in more detail today. So continuous glucose monitors, or CGM, provide frequent real-time glucose readings, which can be used to help prevent low blood sugars, hypoglycemia, or high blood sugars, hyperglycemia. Insulin pumps, which the scientific name is continuous subcutaneous insulin infusion, or CSII, can be used to continuously deliver small amounts of insulin to more mimic what the pancreas would do in someone without diabetes. And then finally, there's a number of names for closed loop systems or automated insulin delivery or AID, where both a continuous glucose monitor and an insulin pump are used together, along with a mathematical algorithm, so that insulin delivery from the pump is automatically adjusted based on blood glucose readings from the continuous glucose monitor. So what are the benefits of these technologies, the insulin pump, CGM, or the integrated system? There's a number of benefits that have been demonstrated repeatedly in studies. So first of all, they help lower hemoglobin A1C levels, which is our measure of long-term average blood sugar levels. They help reduce hypoglycemia or dangerous blood sugar levels. There have been a number of studies that have shown improved quality of life. So people using diabetes technologies have reduced burden and feel that these systems enhance quality of life. Um, and then finally, they provide additional data, both for the person living with type 1 diabetes as well as for the healthcare team that can help inform decisions and lead to more precise and more accurate decisions regarding insulin dosing. So let's move on to inequities in diabetes technologies. So I've demonstrated, or I've spoken about the number of benefits, but what about inequities in access to these devices? So unfortunately, differences in technology access um, uh, relate to different diabetes outcomes. So this picture is demonstrating the difference between equality and equity, and you may have seen this photo before, but equality is providing the same resources to all individuals, regardless of their kind of baseline differences, whereas equity ensures that everybody has the same opportunity for the same outcome. So that may mean that certain individuals need more resources in order to achieve the same outcomes than somebody else. So socially disadvantaged groups are disproportionately affected by diabetes complications and poor diabetes outcomes due to lack of or poor access to technologies. We use the term social disadvantage to describe individuals who have historically been disadvantaged in the past. And this may be due to belonging to a racial or ethnic minority group, having low income or low levels of education, having immigrated to a new country. There are a variety of factors that can lead to this, and we kind of describe this as a whole as social disadvantage. And we know that people with type 1 diabetes and social disadvantage have higher blood sugars, higher rates of diabetes complications. And one of the factors contributing to this is less use of these diabetes technologies. So this leads us to our equated project, which at its core is trying to tackle the problem that adults with type 1 diabetes from socially disadvantaged communities, such as what I just described, are less likely to use diabetes technologies compared to those who are not living with social disadvantage. And this contributes to worse diabetes outcomes in these populations. So this project has three objectives that we are addressing. The first, which is underway and nearly complete, is to quantify disparities in Canada in terms of access to diabetes technologies and describe the impact this is having on diabetes outcomes. So this seems like a very fundamental and basic piece of knowledge that we should know, but we actually did not have this information specific to type 1 diabetes in Canada. And so we're using a variety of data sources, including the Better Registry data, which I will speak about in a moment, to actually quantify and demonstrate that these disparities are existing and that this is an area that needs attention. The second phase of the project will be to more comprehensively identify enablers and barriers to initiating diabetes technologies among adults with type 1 diabetes who are living with social disadvantage. So this particular group of individuals who we suspect are having lower uptake of diabetes technologies. And then our third objective is to co-develop, which means we will incorporate patients with lived experience to help us. That's what the co-develop process is, to bring together researchers and patients with lived experience to develop and refine an intervention or a strategy, which we would then implement to increase the initiation of diabetes technologies among socially disadvantaged adults with type 1 diabetes. So I'll speak in some detail about the study we undertook to quantify disparities in technology use among participants of the Better Registry. So our purpose was to see how social disadvantage affects the use of insulin pumps and continuous glucose monitors, or CGM, in adults with type 1 diabetes. It says in Canada here, but I should actually qualify that our study was restricted to those living in Quebec. So it's really a study for those participants based in Quebec. And that's because at the time we did the analysis, the vast majority of Better Registry participants were in Quebec. And so we had very small numbers of people living outside of Quebec. Since then, the registry has been expanding beyond Quebec. So the people who we included in our study were adults living in Quebec, so 18 years and older, who have type 1 diabetes, or we also did include those with LADA, or latent autoimmune diabetes in adults, as long as they were using insulin. So in the registry, there are some participants with LADA who are not yet using insulin, and we did not include those individuals because they would not be using an insulin pump if they're not using insulin. And obviously, we included individuals who had completed the Better Registry questionnaires. So in terms of the people that we included in our analysis, we had 2,401 individuals. So I think as you saw in that earlier slide, the total number in the registry is larger now than when we conducted our analysis last year. The average age of people included in our analysis were 41 years old, with most being between the ages of 30 and 55. And then in terms of the sex distribution, you can see that 2/3 of the sample were female and 1/3 were male. So there's a lot of information here that I'll walk you through, but our factors that we were interested in mainly were these descriptors that could describe social disadvantage. So we looked at race, and we saw that 90% of participants in the registry were white. Because the number of individuals who are not white for other categories was quite small, for statistical purposes, we categorized race as white versus non-white, essentially. And we weren't able to look at specific categories otherwise because the numbers were too small. We saw that 89% of participants in the registry were born in Canada, and only 11% had immigrated to Canada. 17.5% of participants had high school education or less. So the majority of participants in the registry have higher levels of education, including post-secondary education. The majority of participants in the registry had income levels higher than $50,000 per year. So there was a smaller number of participants with lower income levels under $50,000 per year. 60% of participants have full-time employment. So again, a smaller number of people had other employment status, which included part-time, retired, unemployed, or being a student or volunteer. And then also, as alluded to on the first slide, we looked at insurance status, and we saw that 25% had only public insurance. So the rest had either private insurance and public insurance, or just private insurance. So the main outcome we were interested in was use of technologies. So that was insulin pump use, and continuous glucose monitor, or CGM use. So in our analysis, we had approximately 37% using an insulin pump, with the average age of pump initiation being 30 years old. And we had 82% using continuous glucose monitors, or CGM, with the average age of CGM initiation being 39 years old. I mentioned earlier that we're also interested in automated insulin delivery, or closed loop systems, where these regarding those systems was added later on. And so at the time we did our analysis, we did not have, for the majority of participants, the information about whether they were using these systems in conjunction or not. So some of the diabetes outcomes we looked at were being hospitalized for diabetes in the past year. 6% of individuals, and then whether participants had ever been hospitalized for DKA, or diabetic ketoacidosis. So this is a condition with dangerously high blood sugar levels where acids start to build up in the blood. And 7.5% of participants had experienced DKA in the past at any time, at the time they completed the survey. So to summarize, we found that 37.4% of individuals use an insulin pump, and 82.5% with use CGM. And we found that adults with type 1 diabetes in Quebec who had social disadvantage, so they were non-white, low income, low education, had immigrated, or had only public insurance, were less likely to use an insulin pump or CGM, and were more likely to experience worse diabetes outcomes in terms of those hospitalizations for diabetes or having DKA. So some other findings, we found that females were more likely than males to have higher A1C. So that's that measure of long-term average blood sugar. Those who were unemployed were more likely to experience severe hypoglycemia or low blood sugar level. Those with low income were less likely to use insulin pumps and CGM, more likely to have higher A1C, severe hypoglycemia, and hospitalization. Those with lower education levels, so high school education or less, had higher A1Cs, so higher blood sugars, and were less likely to use an insulin pump. Those who were not white had a higher risk of severe hypoglycemia. And those with public insurance only were less likely to use both insulin pumps and CGM. So let's talk a little bit about disparities in diabetes technology access and use. So there are a number of financial and insurance barriers to accessing diabetes technologies. In Quebec, people living with type 1 diabetes under the age of 18 are eligible for the insulin pump access program. But for adults who are not enrolled before the age of 18, so obviously including those who are diagnosed after age 18, which we know is about 50% of all people with type 1 diabetes, then they're not eligible for the insulin pump access program, and they cannot receive public funding for an insulin pump. For CGM in Quebec, coverage is available generally for individuals with type 1 diabetes. So there are specific criteria, but they do apply to most people with type 1 diabetes. So there are issues with affordability of the device and out-of-pocket expenses, restrictions on public insurance, not having insurance coverage for all age groups. And then even beyond the financial and insurance barriers, there are administrative burdens to first even being aware of or understanding all of the options for funding for these devices, and then the process for actually obtaining and using these devices. There are some additional non-financial barriers that may disproportionately affect some people. So there are some physical and technical challenges potentially, including discomfort and skin irritation from wearing these devices, feeling that the devices interfere with daily activities. There can be issues technically, so with using the devices, with running into challenges and knowing how to overcome, technical issues that might occur. There may be difficulties with interpreting the data from these devices. There are also a number of provider barriers. So this could be the physicians or the other healthcare providers involved, such as diabetes nurses or dietitians. There's been a lot of studies that have looked at what's called implicit bias and gatekeeping. And that's where healthcare providers generally unintentionally, although it could also be intentionally, but kind of select who they may recommend diabetes technologies to. So they may have preconceived ideas about about who is a good candidate for a diabetes technology, and they may not recommend these devices to certain patients if they worry that these patients aren't ideal candidates for these devices. And so we know that's been a big barrier and one that needs to be overcome in order to improve equitable access to diabetes technologies. There are also a number of structural and social determinants relating to access of diabetes technologies. And so this can include geographic location. So, where somebody lives might have an impact on their access to diabetes technologies. It may impact the access to healthcare providers who are familiar with these technologies. We know that there is systemic racism that impacts the healthcare system and the ability to access diabetes technologies. And so there are a number of social and structural determinants that affect accessing diabetes technologies. So what are some strategies for improving equitable access? So we've done a review of a number of studies that have looked at this, and they can kind of be described in three main areas. So the first is patient-centered support. So studies have shown that providing culturally and linguistically, so language-tailored education can be helpful. Providing simplified educational materials to improve health literacy. and then addressing stigma and emotional barriers related to technology use. The second category would be healthcare system improvements. So that's providing training and education to healthcare providers to reduce bias and to reduce this gatekeeping effect, where technologies are not offered to all patients. To streamline insurance and approval processes. So often this can be quite burdensome, the administrative process of starting a technology. And so simplifying this process can be helpful, and then standardizing clinical workflows for initiating technology. So by standardizing the process, hopefully reducing inequities. And then the third category would be at a higher level, so policy and structural changes beyond just the healthcare provider level. So that's increased funding from the government for equitable access programs, community partnerships to enhance outreach and engagement with people living with type 1 diabetes, and investment in patient-centered research and innovation to reduce disparities. And so the path forward, so our project is very interested in this. By removing barriers and implementing targeted strategies, we believe we can improve access for all individuals, especially those from historically socially disadvantaged communities. And achieving equitable access is not just about technology, it's about ensuring every person has the opportunity for better health and quality of life. So I mentioned, I've shown you already our better registry analysis. And the second part of our project, which is currently underway, is trying to understand in more detail the enablers and barriers to initiating diabetes technologies for people with type 1 diabetes who are living with social disadvantage. And we're doing that by conducting interviews with people living with type 1 diabetes, as well as with healthcare providers who provide care for people with type 1 diabetes in both Ontario and Quebec. And we hope that we'll be able to share these results soon, as we're still in the process of collecting all of this information, and then we'll need to analyze and understand it. And if you're interested in hearing more about the Equated project, our study website is listed here, www.equated with a T1D.ca. So you can find out more information about the study there. We also have posted some summaries of the better registry analysis that I just spoke about today. And we will be continuing to post updated results as we have new results to share from this study. And so I will stop there, and then I'm happy to take any questions.
Thank you very much for this presentation, Dr. Weismann. That was very interesting, and to see numbers and stuff, that's very good thing to know. So we have a few questions. The first one I'm going to ask you is someone sent me this question before the webinar, and the person was wondering, how will interprovincial access equity be ensured, given that provinces are individually responsible for access decision based on their budget?
Yeah, so that is a big problem. Our healthcare systems are provincially administered, and so we already have this situation where someone living with type 1 diabetes in different provinces have different access to publicly funded technologies. And as an endocrinologist, I've experienced firsthand patients who have moved provinces, and then the access changes just because they've moved. It's a real challenge. I think recently there's been interest in a national pharmacare program, and there's been some discussions about diabetes technologies being included within that program. But this is politically driven, and we're at a time of political change nationally. So, there's a lot of uncertainty, if this program will be solidified and how diabetes will be incorporated in it. So there's a lot of advocacy going on in this area, but it is unfortunately a big challenge. And I think each province is working to obtain universal funding within their province. And hopefully we'll get to a point where the provinces all have public funding for CGM and for insulin pumps, which right now, unfortunately, is not the case.
Yeah, let's hope so. I have another question here. I'm not sure if you can answer it or not, but someone was questioning about the strategy that will be used to ensure access to new treatments, such as the, I don't know if I'm saying that well, Langeran islet encapsulation or any other treatments, like the new ones. stem
Sorry,
cells.
so the questions about the new treatment, sorry, can you just
Yeah.
repeat it?
Yeah, what strategy will be used to ensure access to those new treatments?
Yeah, so those treatments are not available yet. So they're being actively researched, but not available right now outside of research settings. So, currently we have some transplant programs, but there's generally clinical criteria for like a pancreatic transplant or an islet cell transplant. So it's clinical criteria based. And because those programs right now require immunosuppression, so, just like if somebody has a kidney transplant, they need to be on long-term medications to suppress their immune system. The current any type of islet cell transplant or pancreas transplant program does still require those medications. So there are criteria that impact social disadvantage because they have to believe that the person will have good adherence to those long-term medications from a safety perspective. So there has to be, somebody who can follow up regularly and come to appointments and be able to afford those medications if they're not publicly covered. And so that does impact equity. I don't think we know yet what the next kind of phase of these treatments will look like. Like the hope is that there will be transplant programs that won't require immunosuppression, but that's still an area of research. I think whenever there is a new treatment, we do need to have equity in mind to ensure that we're offering it to all those who need it.
Yeah, of course. Thank you. And here I have a comment from someone who's been living with a severe vision loss, and she's using a Dexcom G7 with her iPhone and voiceover. And the question is it possibly to use safely an insulin pump without using vision? And I would ask, did you see in your numbers, like people with disabilities, is there inequity in there?
I think that's a really interesting question. I don't believe there was a question in the surveys for the Better Registry, or not, at least not one that I saw when we were looking at the data that we had access to regarding disability. I think that's a really important area for research and understanding. So we did not look at that, but I think I think that is still a very important area. Um, and I think there are still challenges, specifically with vision loss in terms of diabetes technologies, and especially with insulin pumps. So I think there are still challenges there that we need to address.
Thank you very much. Someone else is asking, do you have any numbers on rural, remote, urban? Is there something there with inequity? I know you talked a little
Yes.
bit about the place where we're living, but
Um, yes, we did look at that. I can't remember now offhand, but generally we do see reduced access to technologies for people living in rural areas as compared to urban areas.
well, I know you're not from Quebec, but the question uh, is about the RMQ, which cover pumps for under 18 years old, and they want to know when it's going to be available for people older than that, but I don't think we know yet.
Yeah, I know there's I hope some hopeful progress in that area towards expanding the pump program in Quebec. But I don't have an answer to that question of when that would be.
Yeah, we're the only province that doesn't cover for adults right now, so I guess we'll get there sometime, someday. Here, have there been any barriers reported related to the range of insulin pumps and CGMs available? In some countries, there are a great number of different types of insulin delivered systems and CGM options compared to countries such as Canada. Could the limited access to other new treatment options, such as other brands of insulin delivery systems, have an impact on access?
Yep. So I think it's interesting. So in Canada, a device or a product has to first receive Health Canada approval. So that's at national level. So any new medication or any new medical device is reviewed to determine its safety before and clinical effectiveness that that it works before it would be approved by Health Canada. So each new insulin pump or new continuous glucose monitor device or brand has to first be approved by Health Canada. And a lot of the delays in Canada, because we often are delayed compared to other countries in approvals of new devices, is often at that level. We see products implemented in the United States and in Europe, and they're not yet in Canada, and that's because they're not yet approved by Health Canada. Um, so there's that delay. And then once a product is approved by Health Canada, then the funding for that product, whether it's going to be publicly funded or not, is determined by each province. And we see differences in that as well. So it's interesting, like in Ontario, where I'm based, and we do have insulin pumps publicly funded for everyone, adults and children. We don't have any restriction on the specific pump. So we currently have, I believe it's four brands of insulin pump that are approved in Canada, and all of those would be available in Ontario through the public funding program. So the patient who's applying just basically gets to choose which pump they want to use. Whereas in British Columbia, where they also have a pump program for adults and children, they actually are much more limited and they only publicly fund one, maybe two types of insulin pumps. And so they've made that decision at a provincial level. So the options also can vary depending on the province someone lives in. I think overall, generally using these devices, like going from not using one, not using a CGM to using a CGM, or not using an insulin pump to using an insulin pump, you see these big benefits. If we start to compare differences between specific types of pumps or specific types of continuous glucose monitors, the differences are often smaller if you're comparing between. So the big push is really to be able to access these devices. And of course, we want people to be able to choose because there's a lot of individual preferences. But generally, like going from no device to a device is where you see the big benefit, and the differences between the companies or the products is not as influential or impactful.
Okay, thank you. Interesting. Another question here. Have you looked at discrepancies across Canada due to different access of public access?
That's a really great question and a really important topic. And we're unfortunately quite limited in our ability to do that. And there's a whole variety of reasons for that. But one is that first of all, the data is not necessarily even collected in all provinces. So we still have a data issue in terms of being able to even say how many people with type 1 diabetes there are in each province and what proportion of people with type 1 diabetes in each province are using technologies. So we're actually limited to even have that information, let alone start to compare between provinces. And that's why something like the Better Registry is so important, and participation in the registry is so valuable, because we need to, like as we did with the Equated project, we need to demonstrate the disparities to then try to advocate for better access. And then even if we have data in some provinces, there's a lot of barriers and challenges to trying to share data between provinces, because there's a lot of restrictions for privacy reasons and others. That the data is kind of carefully guarded, and therefore actually trying to share data between provinces can be really challenging. So in our Equated project, we're looking at Ontario and Quebec. So we do have data available for both of those provinces. We chose those provinces partially because we have the data and not all provinces do. And then also because we have an opposite funding situation in Ontario and Quebec. So in Ontario, if we look at adults, we have the pump program, whereas in Quebec, you don't. And then the converse is also true. So in Quebec, you have good CGM access for people with type 1 diabetes, whereas in Ontario, we actually don't really have good CGM access. We have some, but it's quite limited. And so we decided to do that comparison between those two provinces because we could look at differences and disparities to pump access and CGM access in the context of these opposite kind of funding situations. But it's really challenging to try to look across the whole country. So that's partially why we only chose these two provinces. So I think we need to, but we're not there yet, unfortunately, in terms of our data and then our ability to kind of share data across province borders.
You. And speaking about CGMs, have you looked at issues with delayed access in Canada to technologies vs other countries? For example, the Libre 3.
So sorry, what's the question? Have we looked at delayed access?
Yeah, between.
Yeah, so the Libre 3, so that's an example of a product that's available in other countries, but is not yet available in Canada. And we often, for most products, are delayed compared to the United States and compared to Europe. So we don't have Health Canada approval yet for Libre 3, so it cannot be used here yet. I don't think we have a timeline for when it will become available. And my understanding is that's often an industry decision, so the company's decision in terms of where they're prioritizing launching, because they generally only have so much product, especially early on, and they have to prioritize which markets they're launching in. And I think unfortunately Canada's often not a priority because, our population's a lot smaller than the United States and Europe. And so we're often not the first country to launch a product in, unfortunately.
Bad, but what can we do? So, how have you and the team delineate between factors that may contribute versus primarily drive access to technologies? For example, we know that women face barriers to medical services based on gender bias and lack of research and treatment, which might be a larger contributor to, say, ethnicity or economics. This person want your
So
thoughts.
yeah, so there are some statistical methods for trying to sort of isolate, factors. So we were able to do that. So we were able to say kind of adjusting, controlling for whether someone's a man or a woman. How much does income impact likelihood of using technologies or impact diabetes outcomes? So that information is available on the Equated website if you want to look at some of the details. We also tried to incorporate what's called intersectionality in the analysis, which was kind of a new method that hasn't been looked at very much. So intersectionality is trying to consider someone's unique social position and the fact that it is determined by multiple factors. So we don't want to just say, accounting for whether someone's a woman versus a man, how much does income impact? We want to say, a woman who also has low income, are they disproportionately less likely to use a diabetes technology because of this confluence of factors or multiple factors? So we did kind of look at that. Again, that information is on the website. But there's only so much statistics can really capture, right? And so that's why the second part of the Equated project, we're actually going to be interviewing people and talking to people, I think will give us a lot of insight as well to try to understand people's experiences.
Yeah, and there's an attendee here saying that they are not socially disadvantaged concerning like income, education, race, etc. But this person is not able to afford, for example, the $100 every 10 days for CGM. And the person is asking, is there any reason why the provision of pumps and CGMs aren't looked at on an individual basis?
I'm not sure what you mean specifically by that. I mean, we think the standard of care right now, and actually we have national guidelines that have recently been updated to reflect this, that for people living with type 1 diabetes, the standard of care would be that everyone should be offered, everyone who can safely use insulin pumps and CGM and automated insulin delivery should be offered it. That doesn't mean everybody would choose to use them, and that obviously needs to be, respected as well. But we do want to offer it for everybody. That means that we need public funding for everybody because we can't expect for, people to be paying for this out of pocket as they're very expensive technologies. So the equitable access piece is really advocating for access to everybody. So I'm not sure what the question means on an individualized basis.
Well, I guess maybe the person was saying that even though you do not fall in a disadvantaged category, you might not be able to have
Right.
access. I think that,
Right. And so I think what we're advocating for and Breakthrough T1D, formerly called JDRF Canada, calls their campaign Access for All. So that's what we're advocating for, is that everybody should have access to this, whether you meet social disadvantage, criteria or not. Our research is specifically focusing on the socially disadvantaged group of individuals because that is a very high risk group in terms of not using diabetes technologies and then having kind of worse diabetes outcomes. And research has shown, and I can use Ontario as an example, that even if you fund the technology, so we have the insulin pump funded in Ontario, socially disadvantaged individuals are still less likely to use the technology. And so that's the piece we're trying to understand. It's more than just the financial barriers. That's kind of like the most minimum or most basic. You have to overcome the financial barrier. But even when you provide the technology, let's say at no cost, there are still barriers. And those are the barriers that tend to disproportionately affect individuals who are socially disadvantaged. And that's where, healthcare provider bias or stigma might come in, racism, language, difficulties if English is not your first language. And so those are the additional barriers we're trying to overcome.
thank you. And do you have any plans to expand the research outside of Eastern Canada?
So this specific project, unfortunately, not. It's well underway, and it is focused on Ontario and Quebec. I think, the Better Registry is now expanded. And I think there's a lot of interest in this by different researchers across Canada. So this specific project, unfortunately, is focused in Ontario and Quebec. But I think we're going to see a lot more development in this area across the country.
People saying that it's not true that all adults are covered everywhere. Like someone saying in, I think, Newfoundland, it's up to 25 years old. And in Ontario, they don't know if any, like all the adults are covered. It's really different from one province to province. And you have to look at the criteria and I
Yeah,
guess.
in Ontario, everyone with type 1 diabetes is covered. There are still some residual costs in terms of the supplies I mean, I can speak about Ontario most specifically. So the government provides some money toward the cost for using an insulin pump for all of the supplies, but that amount hasn't changed since the program started in 2008, and we know that it doesn't cover the full amount of the cost. So there's still an out-of-pocket cost, but the pump itself is fully covered. Um, there is a table on the Diabetes Canada website that actually compares diabetes technology funding between provinces. So that's a really great resource if you're interested in looking at the differences between provinces. And I would also just say this is a constantly changing thing. There was just an announcement for Saskatchewan, I believe, last week, about expanding access to insulin pumps. So, it's changing quite rapidly, which is a good thing because we're constantly hearing new announcements of expanded funding for some provinces.
Well, let's hope that everybody across Canada will be one day like granted the access to any option they want. So
Yeah,
it's 1:45, maybe 1:46 from precise. So I guess we'll have to end this webinar. So thank you very much, Dr. Weismann, for your presentation. That was very interesting. And I want to invite you all to our next webinar that will be on April 24th. It's going to be on parenting with a kid living with type 1 diabetes, of course. So I hope you can join us in April on our next webinar. And now I'm just saying have a good rest of the day. And thank you again, Dr. Weismann.
my pleasure. Thanks for attending.
Thank you. Bye-bye.